It's been a long, fun day, and think of this, we're all maybe a little bit tired. Hang in there. This is going to be fun. You can think of it like an intellectual happy hour before the real happy hour starts. So we have two great panels here for you today, one on behavioral health and one on diabetes. And you might be, if you are working in neither of those particular clinical areas, I just want to say you're going to hear a lot of very transferable lessons and ideas from both of these panels. So I'm glad you're here. Our first panel is the behavioral health panel, and the conversation focuses on behavioral health and explores how ECHO creates supportive learning communities where providers can explore new ways to help their patients and build up their own resilience while improving patient care. And Director of Medications for Opioid Use Disorder ECHO, Julie Salvador, will be leading us through this conversation. So Julie, take it away.
Hi, everybody. Sorry about that. I'm Julie Salvador, and I am the Associate Director at the Division of Community Behavioral Health in the Department of Psychiatry and Behavioral Sciences. And I have an ECHO that I've been running for about 5 years, and so I've been asked to facilitate this panel. So we're going to start with just brief introductions. I know that you guys see the names, but you might not be able to read all that and certainly associate with faces. So, Eva.
Hello, everyone. I'm Eva Serhal. I'm the Senior Director of Virtual Care in ECHO Ontario Mental Health and the ECHO Ontario Super Hub at the Centre for Addiction and Mental Health in Toronto, and an Associate Professor at the University of Toronto.
Hi, good evening. My name is Prabhat. I'm a Professor of Psychiatry at National Institute of Mental Health and Neurosciences, Bangalore. We started ECHO, and now I head the addiction ECHO at Nimans, Bangalore.
Hi, everyone. I'm Joanna Katzman. I'm a neurologist in pain management doctor. I started the chronic pain and opiate management program in 2008 and have continued the program in various kind of renditions and direct many of the other public health programs at Project ECHO, and glad to be here. Thank you.
I'm Aarti Prasad. I used to be at University of New Mexico. I was here for 23 plus years. And then I moved to Minnesota for the last 5 years. I'm currently the Chief Strategic Development Officer at Hennepin Healthcare. I've been involved with Project ECHO since its inception at UNM, and then planted a seed of that in Minnesota also. Right now, my disclaimer is that I'm representing Team Minnesota. We have our partners here from northern Minnesota as well, the other ECHO team. So what I'll be talking today would be the representation of all of our work here.
Thank you. Thanks, everybody. So just as a quick overview, Dr. Aurora had reached out to me and others on this panel to get together. And the one thing that he had expressed to me that he really wanted to make sure we communicated, and if you guys have questions about, is the outcomes. So some of the ECHOs, we have a lot of ECHOs that get some kind of what we call short-term outcomes. But a lot of our ECHOs have really had some great documented and published data using Medicaid and other data that we're collecting in research studies to show the relationship between being in an ECHO as a provider and actual changes in practice and outcomes. And another thing that we're going to be talking about today are some of these more unexpected outcomes. So some of it has to do with some state funding or legislative funding to keep these going and sustainable, but also ECHOs that really have been flexible and create these communities of learning and support for providers around burnout. So we often think of an ECHO as teaching providers so that patients can get better. But a lot of providing care means that they have to also have supports and ways to improve their own kind of personal outcomes in terms of being able to have better wellness for themselves. So we're going to start with just a brief overview of the projects. We have a brief time together, so I just want to, open it up to the panel to talk. So I will start with Joanna Katzman, just to mix it up. to talk a little bit about, just briefly, what the echoes that you run and then what you're going to kind of focus on today.
Okay. Well, just very briefly, I've been involved, I've really had the privilege to be involved with many different kinds of programs, starting with working with New Mexico clinicians in 2008 and ongoing, except for a brief hiatus over the past couple of years, for which we're going to restart again. And then our team helped to replicate the chronic pain echo with the Veterans Affairs. We helped the Department of Defense and the Indian Health Service, the U.S. Public Health Commission Corps officers, and then most recently, we helped, we've been in a continuous collaboration with the Centers for Disease Control to help primary care clinicians all over the country as clinicians, there's certain clinicians that might have lost their license due to injudicious prescribing. We've been helping to train primary care clinicians in those jurisdictions, accept those abandoned patients. But I'm just most excited about the experience that we're having with our New Mexico chronic pain and opioid echo, Julie. Yeah, so just lots of different echoes, and I guess the New Mexico primary care pain and opioid echo is the one that really excites me the most.
Great, thank you. And I'm learning a little bit. I've worked with you for a long time, but a lot of really big echoes in the VA and the Army and the Navy, and so just huge things, CDC. I'm going to actually go next to Arti Prasad to talk us a little bit about your echo.
Great, thank you. So as I said, I'm representing my team here, and our co-lead for this echo I was not able to attend the conference, so what I'm presenting today is what I have observed, what I have discussed with them, and how I have seen the results of our work in Minnesota. So in 2017, we started our first opioid and addiction care echo, which was initially funded by the state, and there was one goal: to have more prescribers of buprenorphine in the state. At the same time, our partner organization in Little Falls, they started a similar echo. So we had a longitudinal echo series through these two echoes, as well as we had some boot camps. And boot camps are like mini conferences that we conducted over a period of time to train providers in buprenorphine prescribing. That was the first echo. Then we received more funding from the state to expand on these echoes, and we were able to add a viral hepatitis echo as part of the addiction issue. One of the outcomes of addiction is infection, hepatitis, viral hepatitis. So we started that echo. We also participated in the COVID-19 nursing home echo, and we were able to serve majority of the nursing homes in Minnesota as well as North Dakota. And then we have bifurcated our echo and created two little echoes, which are going to be expanded over the next few years. And one is in race and equity related to opioid, and second is in perinatal substance abuse.
Thank you. And I'm going to continue on the North American continuum with Eva to talk about your echo.
Thank you. So our journey with ECHO started, I think, in 2014. We were running a virtual mental health clinic, which had significantly long wait times, which I think is a story for many. And we were looking for a way to really move beyond that one-to-one and start to really get to the one-to-many approach. And so we came to MetaECHO in 2014 with some colleagues that were starting a chronic pain echo. And just the approach was so powerful, seeing that there was an evidence base, but also that echo was, it had fidelity to principles, but not necessarily fidelity to processes or structures. So there was still an adaptability that we could bring over to Canada and adapt in our context. So we started by funding one mental health echo for a 3-year demonstration project. Our early indicators around our implementation and adoption and some of the early outcomes that we saw put us in a position to be able to put forward a grant, or not even a grant, an application for base funding for 6 new mental health echoes. And so we were funded year over year. It became quite a sustainable model. We developed basically a centralized team that was then supporting new and evolving mental health echoes. And we also became a super hub along with our colleagues who support the chronic pain echo. Right now, we have 15 mental health-related echoes that we run. The most recent was one called Coping with COVID, which was amazing because we were able to leverage the structures, the knowledge, the expertise that we had to basically get a new echo up to support healthcare providers, supporting the epidemic within a week, I think it was. So. We've been, it's been a great journey with ECHO, and glad to be able to share our story here.
Great, thank you. All right, I'm going to get to you, but just because we're sort of on the North American piece, I run an ECHO here, the MOUD ECHO, in New Mexico, and it was funded by the Agency for Healthcare Research and Quality. We just wrapped it up. And that ECHO is also, it's to help prescribers that are new and that aren't prescribing buprenorphine. Primary care in New Mexico, only in rural areas, so that was our focus. So that was that ECHO as well. Now I'm going to shift to India, where your ECHO is very expansive, so it's really different. Talk a little bit about that.
I think, Julie, before I start, I think I want to go back a little bit and talk about how you knew about ECHO in India. First of all, it's pretty far from US. So basically, looking at the challenges that we have in India, around sort of 80 million alcohol addiction, and we have 10,000 psychiatrists at this point in India. So working at the institute where you work, sort of National Institute, there is always a sort of vision that you need more people, more experts in the locality, and we used to do same thing. But in 2013, actually, I came to know about ECHO. I came here, stayed for 3 months, ECHO, and sort of learned, we are looking at a scalable solution that can it be scaled up much faster than whatever we should do. And that's where the ECHO came to picture, I think, thanks to Sanjeev and ECHO team that they sort of allowed me to come here. And we started our first ECHO in 2014 March. So then it's become a journey. Another challenge was to how to integrate ECHO into the system itself, because you can run ECHOs and sustain it and sort of expand it. So at this point of time, obviously, it has been integrated to the institute, and many hubs have come up. So this is a journey. We started addiction, but then another expansion was that your colleagues should also take over and they should do the program. So we have perinatal mental health as a separate team, geriatric, child, adolescent. So it has actually captured the attention of the system and the government so that the sustainability, say whether we are there or not, it can happen. So this is our journey of ECHO. Thank you.
Thank you. Now I'm going to shift a little bit, now that we've had a little introduction to our programs. I want to shift to the outcomes. And then, of course, we'll get to some of the stories. And the outcomes are both planned. Obviously, some of the things we expected. And then people have already alluded, like Arthi, to some of the outcomes, like it became funded by legislative dollars. Ours became funded as well. So I'm going to kick this one off just to get us on the roll. My ECHO was, I had actually sat in on one of Joanna's ECHOs and for a long time, and I thought, I really want to do a study to look at the relationship between it showing up, attending sessions, and looking at changes in prescribing and adding patients on to treatment for buprenorphine. So I wrote a grant with Dr. Snehal Bhatt, who I know is in the building somewhere, and we've been conducting that, and our outcomes really showed changes, and our statistician is with us as well. It really showed changes in prescribers getting the training. If you attended more sessions, you are more likely to get your training and licensure and anything you needed. You are more likely to prescribe for the first time to new patients, and you're more likely to add on to your patient panel. So having, and even one of our prescribers, which I'll get to in my story, has really expanded. So that is a publication that'll be coming out soon, but that's the kind of outcomes that I think we're looking for is people, we know providers like it. We know that changes are happening and we're starting to document really clearly what's happening. And then some of the unexpected outcomes, of course, where we've got state funding now to run that ECHO, so without the research funding anymore, so that's great. So let me move let's do Arthi. Talk a little bit about your outcomes.
All right, great, thank you. So as you know, we are not supposed to use PowerPoint slides during this presentation, so we have our props, if I mess up. So when we started our ECHO, there was a lot of hesitation from providers to learn about buprenorphine, and prescribing, because that's not the normal thing you do in medicine. So we actually partnered with the MMB, which is the Minnesota Management and Budget, which is an organization through Department of Human Services, and they have started to look at the state-funded programs to see how well their grantees are doing. So we partnered with them on an evaluation process, and they looked at Medicaid claims data for us for both the longitudinal ECHO series as well as for the boot camp. And these results were published in 2022 in the JAMA Health Forum. And this was the first publication that actually showed that there was a patient-level impact due to the work that we were conducting through ECHO and then these boot camps. So what it showed that is, compared to the providers who did not attend the ECHO training, the providers who attended the ECHO training were more likely to prescribe buprenorphine, significantly higher than the providers who did not attend. And there was a significant increase in that, and they measured it longitudinally for 6, 12, and 18 months, and they saw those results. They also prescribed to 6.5 more patients when you look at the data they prescribe buprenorphine. And then we also looked at the results of the boot camp, and what they noticed that there was both at 6, 12, and 18 months, the providers who have attended the boot camp training were likely to prescribe more buprenorphine, and there was a 33% point increase among the boot camp providers. As our partners, Stratus Health, who are here, they have been looking at the provider knowledge, the knowledge, skills, and attitudes, and their providers, almost 85 to 90% of their providers have seen the value of this ECHO in their work, as well as personal satisfaction in being able to provide care to these very complex patients.
Great, thank you so much. And I want to move to Dr. Katzman again. Joanna?
Well, thank you. Thank you, Julie and Artie. I think I'd like to talk about our program with the Army and Navy. We started with them quite early, kind of in the history of the ECHO Pain program. We started collaborating with the Army, U.S. Army in 2011 by just the fact that some leadership, some high-level leadership came to Project ECHO to meet with Dr. Aurora, and they introduced themselves to me. One thing led to another, and we had this amazing collaboration with the U.S. Army, then the U.S. Navy, and then the Department of Defense that lasted almost a decade. But starting with the U.S. Army in terms of ECHO Pain, we collaborated with the U.S. Army and then the U.S. Navy for a total of 6 years, and we were so lucky to get to train U.S. Army clinicians in terms of launching ECHO Pain throughout the entire globe, actually. And they came to Albuquerque for boot camps similar, I'm guessing, to Artie's boot camps in ECHO Pain. They would come to our pain center on a quarterly basis, and we would train them about Project ECHO, and they actually developed ECHO hubs throughout the United States in the Western Regional Medical Command, Eastern Regional Medical Command, Northeastern Regional Medical Command. There's about 5 regional medical commands in the continental United States, Asia, and Europe. And to this day, they still have ECHO hubs all over the globe, providing regional care for patients in the Army with chronic pain. Then what happened is the Navy said, this is not fair, we want to do this too. And it got faster. The more that we trained, we were able to do it faster with the Navy. And then the Department of Defense said, we want to create an office of ECHO within the Department of Defense. So this was our collaboration with the military. We then looked at centralized data with the Department of Defense, and we looked at how were actually the clinicians in the Army and Navy doing. Were they taking care of patients better if they were calling in to their own ECHO regional hubs? And our data, our collaboration with many very high-level data sharing agreements, if you can imagine, with the Army, the Navy, and the Department of Defense. It was quite a task to get these data sharing agreements. This data showed that primary care clinicians in the U.S. Army, U.S. Navy, the patients who were whose doctors and nurses and NPs and PAs who were participating in ECHO had a 30% reduction in opiate prescribing and opioid and benzodiazepine co-prescribing. And that's in a nutshell the results. So it was really an amazing ride for the last decade. Thanks.
Thank you. Yeah, and also now just in the essence of time, so we have a little time for questions, I want to turn it to Prabhat and to Ava to talk a little bit too about your outcomes, but also any anecdotes or when you guys really, and I know Ava, yours has a lot to do with that learning community and that support, so I want to give it the opportunity for both of you guys to sort of talk a little bit about your outcomes and some of those unexpected or purposeful connections that providers had. So I will start actually with you, Prabhat.
Yeah, I think one of the outcome which is basically non-measurable, difficult to measure, is the hub team improves in the career, growth of professional, personal. I mean, again, it's not pure outcome, but I mean, just to encourage the future hubs, I think at least for us, I mean, I'm pretty sure for other hub teams, definitely hub teams grows well in their personal and professional growth. Whole 10 years I've started with assistant professor and become full-time professor. So that's uncounted. So this is the anecdote that doing ECHO doesn't help the people, it helps you personally also. Coming back to the sort of tangible outcomes, that we did a small study, sort of a county in India where there are only 31 psychiatrists for 100 million people. And that state actually asked me to train for addiction. I told, look, training does not translate to practice. I mean, they insisted they should train them. I don't know to train them. So I'll mentor them for this. This is in 2016-17. So we did a 6-month telementoring ECHO for them in addiction. At that time, the smartphones are very new, the 4G was new. And so we found that almost they could screen and identify and manage 95% of people in the community who are alcohol use disorder. Only 3% they refer to the sort of higher center. And these are the public facilities. They are out-of-pocket experiment, which is sort of very so if you train somebody, mentor somebody, then he himself can work like a community specialist, and what ECHO actually proves. So there is something I would tell. Yeah, thank you.
Yeah, and what you shared with me prior, I had send me some things in writing. It's just amazing how many people are, and same with these just large programs, there's so many people that are getting services because the providers are willing to join an ECHO and kind of be able to take that on, and it's really doable when they feel supported. Now, on the topic of support, just talk a little bit about your ECHO and that provider community, especially during COVID.
Yeah, I mean, I'll talk really quickly about outcomes as it relates to that, and then
please.
I'll go into my anecdote.
Please.
Okay. So when we first started ECHO, we wanted to understand what the evidence base was. So we published a systematic review using something called Moore's framework, which I think is actually pretty widely used now in ECHO, to understand what the evidence was. And we saw that there's quite a bit of evidence around provider satisfaction, learning, knowledge change, and so on. But there is still quite a gap in evidence around patient outcomes and change at a community or a public health level. So we sort of leveraged that to build our own evaluation strategy. We did start with some of those higher level ones in that, and also looking at implementation outcomes. We really wanted to be able to solidify ourselves in terms of building a sustainable program. So we were able to do that and share our outcomes back with our funder. And now we're looking at how we can leverage more administrative level data. We have used administrative level data to understand who the providers are that are leveraging ECHO, to also help us better understand who is not. And help guide some of our programming. And now I think using administrative data to really understand the patient level change as well as provider level, or and provider level change, but also change on a much more sort of macro level is where we're thinking and turning to now. And in terms of anecdote, I mean, I think we were all thinking a little bit about, you know, what have we seen through ECHO? What are some of those big, you know, important moments for us in ECHO? And I have a couple thoughts of when I thought, this ECHO's got legs. Like, this is something that I can see just continuing to grow. And the first was when, and this is about, you know, the community of practice, when we first launched, you know, we had done all this work in identifying needs. We'd worked with primary care, a primary care association, to identify where primary care providers had said, look, these are our gaps in knowledge around mental health and addictions care. You know, we'd built a curriculum around that, and here we are. I'm sure this again resonates with many. Day one, ready to hit the launch button, and we thought, okay, are people going to show up? They're going to show up to the party, right? We're ready, we're prepared. And seeing the Hollywood squares pop up, and the level of engagement, and seeing the all teach, all learn approach come together, and then seeing that not just from launch, but how it's sustained over time, I think was really powerful. And then being able to do that at a national scale when we started our Coping with COVID ECHO, and then coming back years after hearing, you know, what essentially seemed like a lofty goal of touching 1 billion lives, and thinking, look at the spread. Look at how many people are really leveraging this model. So for me, the anecdote is just seeing, A, the evidence that's continuing to drive this, and B, the passion that continues to grow this. It's amazing to see how it's evolved.
Thank you. Yeah, and I agree. I mean, I think a lot of it just makes sense, and providers obviously like it and believe in it, but I swear when I met with my statistician and he showed me the data, that also just really hit that home for me, just how what people are saying, and there's really evidence of the value of joining an ECHO, participating in it. Does anyone else just want to open it up to share an anecdote or two, and then maybe leave 5 minutes for questions? Yeah, Dr. Katzman.
I just really, really want to add to what Eva is saying, that I think that for me, the thing that really pulls my heartstrings is really the benefit to the clinicians, just the prevention of burnout, the fact that a clinician can come and go as they please over the course of, you know, maybe a year or 2 or 5 years. For in the case of our particular New Mexico ECHO, I think we've really benefited from a state that's large but so rural and so spread out. We have clinicians from, you know, that live maybe 5 hours away from each other, but have gotten to know each other over time, over the course of 5 years, that maybe just have seen each other on our ECHO pain and opiate management ECHO, and yet they maybe have once or twice have seen each other in person, but it's that community of practice that Eva's talking about that's really built up, and yeah, that's really what's benefited. Yeah, thanks.
Yep, please.
I'll add just very quickly about this community building and the joy of practice that Joanna is talking about. For us, it's really been the improvement in access with these ECHOs. So now another smaller safety net hospital south to the Twin Cities sees about 200 patients per week, and it's really a matter of pride for them. And many of these providers have attended ECHO sessions. And when we now create our boot camps, we are able to recommend some of these providers to Minnesota Hospital Association, who has received separate grant for boot camps. And many of the clinics are now working with the local county jails to provide the service for incarcerated patients. And we know the mortality goes so much higher after they leave and there's a discontinuation in treatment. So there's more awareness, there's more training, there's more access, and there are better outcomes.
And I'll just add one little thing. One of our very first providers that joined the ECHO that we were running for buprenorphine, and he was probably the second person to join the study. And then after a while, he had his patients up to 50, and I thought, oh, I'll never see that person again. Well, he's joining the ECHOs again. He's got different questions with telemedicine and different things going on. And he's actually shifted from being a primary care physician that was a little bit, needed some support, to now really running his own separate addictions center. So it completely changed the trajectory of his career. So we have about 5 minutes, and people can continue to share anecdotes, but I wanted to open it up, and I will use my little hand hat. Are there any questions? There are people that have microphones. If there are any questions about the ECHOs or collecting data, I don't know if there's anything that might be of interest to anyone to explore further. Anyone? Well, I don't see anything, and if anyone does, just shout. But I did want to, go back if we have a couple of minutes, because one of the things I think that's, like we talked about, that's important with ECHO is it's great that people get a lot out of it and that we have anecdotes to share, but some of the things around how to collect this data, how to track your ECHO and look at those outcomes, that's feasible for people that are running different kinds of ECHOs. It's really helpful. Oh, it looks like there is a question. So we'll talk about that if we have a minute. Go ahead.
Hi, Kelly with the University of Hawaii. We have a behavioral health ECHO, and we have a challenge with claims data. We know we're going to have access to it in about 1.5 years, but many of our participants are social workers who don't bill. And so we're having trouble using or imagining how to use our claims data to demonstrate the impact of our ECHO. Any advice?
Well, the only person that I think used claims data was Arti. But I don't know if you can.
I don't have an advice on that one for the medical social workers and how to collect that data. We in Minnesota, we have recently gotten the community health workers who are going to get licensed to actually bill. But I'm not sure about medical social workers. If they are working, I'm just thinking on top of my head, so please pardon my response. But if they are working, if they're partnering with a physician who is a biller, is it possible to look at that data? That's the only thing I can think of, Joanna. Yeah. Okay.
Is that helpful? Okay, thumbs up. And I can say in our project too, we had, we just called people and we got some self-reported data, and that was actually publishable. So that's another option if you are stuck with a hard data. Yes, please.
Hi, Leslie Hayes, Espanola, New Mexico. I have a question about getting people to participate in the ECHO. Generally, I have no trouble getting medical providers to offer an opinion. They will talk for 15 minutes if I let them. But, behavioral health less so, in getting peer support and community health workers to offer opinions. They often have really great suggestions that are things I would never have thought of when I do get them to participate. Have you found anything to help with folks, because I think they're just intimidated because they don't have the education level. So what have you found helps with that?
Well, I have some thoughts, but I'm actually going to let other people jump in first.
Yeah, thanks, Lisa. So something I do, I can tell, because specifically we have a language issues in India. So as people who are community health worker or social worker, their linguistic English is not good. We actually do a regional language echo, sort of, which language they speak. We sort of continue that one. That gives them a lot of confidence to come to the video and sort of talk about the challenges. I think that's what, but still when it's a mixed group, it's a challenge. But if you keep a sort of homogeneous group, it helps sort of thing. But I also agree that when the more specialists are there, it's difficult to manage a group. Yeah, thank you.
May I add on, Prabha? Okay. Hi, Leslie. What I would say is I think that's a great question, and I think we have not, with our New Mexico Pain and Opiate Echo, we have not yet brought on a community health worker to our hub team, and I think that is something that we desperately need to do, because I think that that will help us engage community health workers more so on to our New Mexico Pain and Opiate Echo that we're going to be restarting. But I can tell you that we've had for almost a decade, a very successful CHW opioid echo, which has really engaged CHWs and community health representatives, which are really CHWs working specifically kind of in Indian country. And that has really allowed a space for CHWs to learn about opioid substance use disorder specifically and elements of chronic pain. But I think I always think if you want to bring participants to the table, you really need to mirror that with bringing that scope of practice to the hub team. That's just what I think.
And thank you. So Leslie, going forward, I can talk about what we are planning to do. So with our new state funding, we are going to launch 2 new echoes. One is in community health workers training and the peer recovery coaches training. And we will be developing a primary, secondary, and tertiary prevention of opioid crisis as part of their training. And what we are thinking of doing is conducting a focus group first, so they are in their own peer group, and they can have, more power to speak, feel like that they are part of the group. Because I think what I'm hearing, that there's like a little bit of power difference, when you bring these folks into an echo and providers can talk, but the other people are not providing. So we want to hear them out. We want to have their voice in echoes. And they are going to, after they're trained, and they already have a lot to offer, but this will be additional training. And then we are going to cross-pollinate our new echoes. One we are launching in trauma-informed care, and the other one in integrative pain management. So they're going to cross-pollinate across all of these 4 echoes.
And I'll add, and then I know we're over time by a minute, but I agree completely with having the hub team, like completely. You need to have people on the hub team that represent the people, because then people see their expert on the hub team. And if they don't see it, the hub team's just a bunch of physicians, they're not going to feel that way. But the other thing I would add to those ideas is the curriculum. So if you develop a curriculum, make sure that you have a day when the topic is peer support or community health worker. We have topics on ours on therapy and motivational interviewing, and a lot of physicians don't have expertise in all those areas. So that's where other people can join in and feel like they're experts in the topic that you're presenting in your curriculum. So those are all really good ideas. And I know we're over by 2 minutes, but everyone wants to stay here instead of the award ceremony. I'm just kidding. Well, thanks, everybody. Thanks for attending, and reach out to any of us. You see our names, you can get our emails. If you have any further questions, I'm sure we're all happy to answer them offline. Thank you.